So I'm going to start with doing a little drawing on describing what we do for surgery, for cataract surgery, and then we'll kind of talk about the complications today. So I'll just do my standard drawing of basically the eye here. This is and so here's the lens. The lens sits like an M&M candy behind the pupil, and this is the hazy part. This is the part that gets that obstructs your vision. And so during the surgery, this is what we do. So after we bring you to the operating room and clean you up, we have you wrapped up and sterilized and are lying down on the gurney and looking up at the microscope. And you'll have IV there and anesthesia next to you to give you medicine if you need. If you're feeling a little anxious, just let us know. If you're having any pain or discomfort, also let us know. We can give you more topical medicine, but I want you to be awake and I want you to be looking at the light the whole time. You'll be looking straight up this way towards the light and straight up. And if you have any sort of pressure feeling, I'll usually warn you about that. So I'll times hold your eye with some instruments, and also I'll be warning you before I give you some numbing medications. But so we start off with basically making an incision here in the cornea, and two incisions actually, one for my left and my right hand. And then if you think of this lens as an M&M candy, I'm going to open a hole in the candy shell. And then after I open the hole in the candy shell, I'm going to cut the chocolate of the M&M into 4 pieces. So I cut a groove down the middle, and then I spin it 90 degrees, and I cut it again, and I spin 180, and I cut it again. And then I suck out the chocolate here, and I remove all that. And after that's all gone, it's all what you end up having is a clear candy shell bowl. So it should look like this. So after we have a clear bowl, the lens implant is then inserted into the through a straw as tube and inserted in there, and it looks like a little taco initially when it rolls, and then it gets inside, and then it basically unrolls, and the arms spring open, and it centers itself inside the skin of the old lens. And then we wash everything out, and we clean out all the jelly that we're using to stabilize and protect the cornea, and so that's called phacoemulsification, and that's the standard method for cataract surgery. Sometimes we put in a specialty lens called either a toric lens, a astigmatism correcting lens, and that's usually because someone's cornea has an irregular, or not irregular, but a football shape to it. So instead of it being rounded, like a basketball, the cornea might be shaped like a football, where one side is instead of it being totally round like a circle, it's more like a curve, where one side of the cornea is steeper than the other way, horizontally and vertically. There's a difference in the curvature, and that is astigmatism. And so we can put in an astigmatism correcting lens inside the eye, and it's aligned up to basically reduce the astigmatism inside and help you see better. And it's an elegant way of removing. Typically, when it's more than a diopter of astigmatism in the cornea, I'll recommend a toric lens. That's not covered by insurance, but I think it's a great option to help minimize the astigmatism after surgery, so that you can see better without glasses, at least for one distance. While we're talking about that, we can talk about the multifocal lens choices. So there's new lenses that have come out in the last few years that we call multifocal, or the new trifocal lenses that allow you to see far, middle, and near distances. And they're not like a standard lens, and they're not like a child's lens. So a child's lens basically can change shape. So when your kid looks far away, the mountain's clear, but up close, their fingerprint might be blurry. And then when they look at their fingerprints in their hand, their fingerprints are clear, but the mountain is blurry. And so that's because the lens is, we call accommodating. It's changing the shape inside their eye, and it adjusts. And that's not how these multifocal lenses work. So the multifocal lenses work because they have different zones. They have rings, and they have different for either distance or for near, and they basically allow you to see the far, middle, near at the same time. So I explain it like if you have a Kodachrome camera and a Kodachrome slide, and you focus your camera for distance, and you take that picture for distance, but the near is blurry, and then you change the focus of the camera and you take another picture where your focus near and the distance is blurry, and then you take those two slides and you superimpose them together. And that's what people typically see at nighttime when they have a multifocal, is they'll be driving behind the car at night, driving at night, and they might have they'll see the car, the two taillights of the car in front of them, but they'll also see like this glowing halo around it, and that's the near image as they're looking at the car taillights. And those halos everyone sees when they have a multifocal lens. There are certain patients that I think are okay to get a multifocal lens. Typically, they're people who hate wearing glasses, and they would rather be blurry than to wear glasses. And so I think for patients who do not typically wear glasses full time when they're getting evaluated for cataract surgery, and I think they're ones that come to me and they're either farsighted or they just prefer just to not wear their progressive lenses, and they are really not fans of progressive, and they'd rather do single vision readers and those kinds of things. I think they might benefit from a multifocal, and so we do talk about those as options, and they come in astigmatism as well. Both astigmatism and multifocal type lenses are not covered by insurance, and those are a premium lens, and we can talk about that. And so those are the premium lenses. So those, but they're inserted in the same way. The only difference is astigmatism lenses need to be adjusted and put into the right axis, into the right football position. So if the football is sitting at 180 degrees and horizontal, then we put the lens implant 90 degrees from that, so we orient it vertically. But if the axis of the corneal football is at 45 degrees, then we have to tilt the lens again at 90 degrees over, and so we have to adjust basically and put it 90 degrees from where the cornea. And so that little adjustment we measure before surgery, and then after we put the lens in, we make a final adjustment at the end. And our new the new Toric 2 lens implant that I typically put in is got frosted edges, and it's does not move. There are some small risk that the lens may rotate after surgery, but that risk is pretty low these days with these new lens versions. All right, so let's talk about some of the complications and what can happen. And there's a few things that are more common. So most common is dryness. So a lot of people during cataract surgery are putting in a lot of drops. They need to be putting in 4 times a day eye drops that have preservatives in them, and their eyes are open during the surgery. I like to coat their cornea with a lot of gel on the front, and it helps keep it from drying out during the surgery. But invariably, people do feel more dry after surgery than before, and that's common. And so about 40% or so of people feel like they're more dry after surgery, but definitely like frequent artificial tears in that post-operative period, preservative-free, clean. Make sure people wash their hands before they use their eye drops, and make sure they use their drops correctly so that they're minimizing inflammation. Next thing is infection. So since we're talking about the incision, and infection is the most serious complication of cataract surgery. The incision is self-sealing, and if you push on the wound right behind it, even weeks after surgery, the wound can be opened again. So it's really important that patients wear their shield They'll be given a shield after surgery, and it's to really make sure that the eye doesn't touch the pillow when you're sleeping, and reminds you not to rub it, because it's really important that nothing gets in the eye in that first week, especially of surgery. And so and then there's so infection. So any pain, redness, worsening vision in that first week needs to be seen right away, immediately. It's a very low risk, less than 1 in 1,000 risk of that complication, but it is a very serious one, and it's the primary reason why we don't do 2 eyes on the same day. So the next risk is, so as we're removing the chocolate of the lens, the capsule is very thin back here. It's only 4 microns thin in the back, and on rare cases, as we're spinning the chocolate and cutting the chocolate out with our instrument, this posterior capsule can tear or break. That happens about 1% of the time, so not very often, but if it does happen, then the pieces of the chocolate can fall into the back, and they'll need to be removed if there's large fragments, and that's called a vitrectomy or lens removal, and the retina specialist will do that for us, and typically in that week after the surgery. It does increase the risk of retinal complications, so retinal detachment risk, higher eye pressure. It doesn't mean you're going to be blind. It just means that there's going to be that extra step, and also it means that we have to put the lens in a slightly different way or anchor it in a different way, typically in front or in front here. So using a different method to anchor it. It also means we cannot put in the premium type lenses. Those astigmatism correcting lenses are too hard to adjust accurately, so we just refund people that, and we don't put those types of lenses in if that happens. So retinal detachment, I guess, is also one. So retinal detachment is, if at any point, especially our very nearsighted, long-eyed patients, if the retina were to start detaching, peripheral vision would start to disappear, and that's an emergency. So people who are more than a -5 or 6 myopia prior to cataract surgery, their eyes are longer, and if, the retinas are typically much thinner out on the edge, and little holes can form, and they're just weaker, and so little shaking and movements and things like that can cause the retina to dislodge. And if that happens and you start noticing loss of peripheral vision, that's an emergency. That needs to be tacked back on right away by the retina doctors, and so just immediately call us and be seen by the doctor on call, or go to the emergency room if no one can, if you're somewhere else or you need to be seen, the retina specialist in whichever place you're at can take care of that. All right, so floaters. So after surgery, there's little chips, that they're as we're taking out the chocolate. Sometimes little chips can float around into this section here. Let me see. So can float into the back out here. If little pieces kind of float, sometimes people notice little floaters. Also, the vitreous jelly, as we're taking out the cataract, can move more, and sometimes people do notice new floaters. And if they don't have a posterior vitreous detachment yet, the vitreous is typically tethered to the optic nerve, and it's the last to separate here. It's called a PVD, posterior vitreous detachment. If it were to happen, right after cataract surgery, you would start seeing a floater, typically in the right eye, 15 degrees to the right, and the left eye, 15 degrees to the left. And that's it happens in everybody at some point, and sometimes cataract surgery can kind of trigger that. That's not that concerning, but if you have flashing lights with eye movements, if you shake your head and you see a lightning bolt go off to the side, close your eyes and do it again and see if that happens. If you close your eyes and that little shimmering of light goes away, that's nothing to be concerned about. That's actually in that first week after surgery. The lens implant is actually just holding on to the side of the skin of your old lens in 2 spots. The rest of it is just floating in fluid, and as you move your head left and right, a lot of people notice that little shimmering of lights and as it glints off the edges of the lens, and that's normal. So that will actually, as the skin of the lens, the old lens, starts to shrink wrap around your implant, will stop doing that, and that shimmering will go away after a few weeks. But people will notice that that shimmering of lights is actually pretty normal. Everyone actually has it if we ask them carefully if they notice it, and they close their eyes and it goes away. The flashing that we're talking about for the retina is if you shake your head or you move your head left and right and you see like lightning flashes off in the side, and it doesn't go away. In fact, it's more noticeable when you close your eyes or go to a dark room. That needs to be checked. Not emergently, but it probably means that the vitreous jelly is starting to tug on your retina, and we need to check to make sure there's no tear or a hole or anything bumping into the retina. Okay, all right. So, the next part I want to talk about is the secondary cataract. So let's say the these are fine. You don't have the floaters, and let's say everything went great, and you have over the course of sometimes a day, so sometimes 3 or 4 years later, you start to notice that your cataract is coming back. You feel like there's a glare at night, and a lot of people will get scar tissue growing on the skin of the old lens. We call it a secondary cataract, and as it grows across the back, scar tissue doesn't grow on the implant, but it does grow on the skin of the old lens. The younger you are, the more likely that happens. In children, it's 100%. But yeah, it's very easily remedied. We basically would do we call a laser capsulotomy. So we use a laser, and it's done in office, and we basically break open a hole in the back there of the scar tissue there, and that basically helps remove that scar and clears up that hazing, so that you're just left with basically an opening in the back. So the lens implant, at this point, we wait as long as we can to do this laser procedure to minimize the risk of this lens shifting or moving or dislocating into the back. But yeah, that's very common, and we just after we do that, vision typically goes back to what it used to be right after surgery. Other concerns. So the measurements that we do about cataract surgery to determine the lens implant is based on two numbers. It's based on two primarily main. There's different formulas and calculations, but essentially it's based on the corneal curvature primarily. That's the main focusing power of your eye, and then the length of the space between the surface of the cornea and the surface of the rods and cones in the back. And so that determines basically the power of the implant that we would use to implant in the eye, based on averages and based on kind of where we call the anterior chamber depth of, where the lens has been in your eye prior to surgery. After we take out your lens and we put the new lens implant, there's still a variable that we can't predict, and that is, how does the skin of the old lens wrap around your implant, and how does it shift? And this is the reason why we wait 3 to 4 weeks to prescribe you glasses after surgery, and that's because the lens can shift forward or it can shift backwards, and if it shifts, it can actually change your prescription. And so it's important to realize that's the primary reason why we can't promise that 20/20 vision using these techniques. And cataract surgery is less predictable than LASIK surgery. Or LASIK, there's a way of shaving off a part of the cornea to clear up the the prescription by just shaving a little layer off of the cornea, and that is definitely much more predictable than the lens implant method. So that's the main reason why we have some of those small differences in what we were shooting for and what we were aiming for. So yeah, refractive surprise. It's uncommon to have big shifts in the prescription between what we're expecting and what we're aiming for. Those differences are greater in people who have either very long eyes or very short eyes. That affects some of the reliability of the formulas. There's some adjustments that we make and things like that. There's also things like history of LASIK surgery. So if someone's had a previous corneal surgery, either RK or mainly LASIK and PRK, and those types of refractive surgeries can change those formulas, and we have new formulas that adjust for those. And but still, those are cause a little bit of increased variability in the predicting of where the what lens power we should choose. If there's a large discrepancy in what happens, we can certainly make adjustments for the second eye, but we can also take the lens out. So the lens can be removed. It is a much more risky procedure than putting the lens in the first place, but it can be done, and so that is an option. In very rare cases, the lens can be put in backwards. So if the lens were to be put in upside down, there would be a small shift in the power. So typically we put the lens in this way, and if basically it were flipped around and then put in upside down, I've never seen this before, never happened before. I'm making recordings. And so if that happens, then we would we could go back in and flip it, or we could adjust it with glasses, and then that's another option as well. So other risks of the surgery. So there are certain patients who have weakened, we call zonules, and zonules are like the strings that hold your old lens centered. And some people have condition like exfoliation syndrome, or they have weakened strings, and these, and they're higher risk of during the surgery, decentration or collapse and weakening of the bag. The skin of the old lens can collapse in on itself during the surgery, or it can even separate and dislocate. Patients are at higher risk of we call subluxation of the lens. So after the lens goes in, if those zonules break, the lens can fall into the back. So if the zonules snap and the lens basically falls into the back, you would need a second surgery to remove the lens or to sew it back into position. And usually, we know which patients those are based on some findings on the front of the lens. Sometimes we don't. Sometimes we find out during the surgery that the zonules are weak and there's some decentration. And there's some techniques we can use to help shore up the edge. There's we call a capsular retention ring we can put in to expand the capsule during the surgery to kind of keep the lens centered and keeps the bag round. Those are some steps as well to help that, but that is a risk that may need to have a suture technique or sewing the lens into position. The other, let's see, we can also talk about the corneal swelling. So corneal and retinal swelling. So corneal edema, there are certain patients who have a condition called Fuchs endothelial dystrophy, and for those patients, they have a weaker, the inside layer of the cornea is a little weaker. You're only born with a certain number of endothelial cells, and if you have less of them, some people have these little bumps called guttae on the inside of the cornea, and people who have very shallow anterior chambers, so if they're very farsighted and their space is tight, or if their lens before surgery was very hard or very dense lens, that energy required to remove the chocolate of the M&M, that energy can cause loss of those endothelial cells, and they can cause decompensation. And so patients after cataract surgery may be more smoky and hazy, and we often increase the steroid dose after surgery to help heal those corneal endothelial cells and keep them alive. But if there's not enough of them after a few weeks of surgery and there's still hazing and smokiness, some patients will need a, we call it corneal transplant. Basically, now the new ones are just replacing the inside lining, and that is a secondary surgery. And so that is a risk that some people may need, especially if they're in that category of problem. So other things, so the let's see, the retinal edema. So certain patients can get retinal swelling. So retinal swelling is something that happens more often in diabetics. Everyone does have a little bit of retinal swelling after surgery, and if it's significant after the surgery, and there may be some persistent fogginess, diabetics have weakened capillaries, and mild inflammation can increase that swelling. There's also patients who have what we call a macular pucker. So if people have a layer of scar tissue kind of on the surface of the retina, that can increase the risk of having retinal swelling. A lot of times people who have a macular pucker and have been seen with the retinal specialist will still recommend that we take out the cataracts first before they entertain doing the macular pucker surgery, and that's common. We often will take out cataracts. Are not too bad, but we'll take them out so that the retina surgeons, when they take out their do the membrane peel, the lens doesn't haze up right in that post-operative period for them. And so, yeah, we treat the swelling of the retina with more anti-inflammatory drops like the non-steroidals and other medicines to help reduce that as well. Let's see. So the one of the very rare risks of surgery also is this we call suprachoroidal hemorrhage. And suprachoroidal hemorrhage is basically a bleeding underneath the retina, and that can happen in patients with very high blood pressure, expulsive hemorrhage we call it, and that can actually blind somebody. So if the bleeding doesn't stop and there's so much bleeding, it was much more common in when the wounds were much larger. Our current smaller incisions are less likely to cause that because we just need to make sure the pressure is elevated high enough to stop the bleeding. But very short eyes are at higher risk, and patients with high blood pressure. And so obviously managing those prior to the surgery is important to doing those. So, all right, so those are, kind of the main things that I wanted to talk about with cataract surgery. If you have any questions, certainly let me know, and I'll talk to you in a few minutes.